So hello and welcome to the Clinical Pharmacist podcast, where we discuss interesting topics relating to clinical pharmacists in general practice. I'm your host today, Becky Barron, and I'm the Digital Marketing Assistant at CPS. Today I'm also really pleased to be joined by Runa. Runa is an experienced senior IP pharmacist, and she's also the Director of Clinical Pharmacist Academy. Hi Runa, how are you?
Hi Becky, I'm good, thanks. How are you?
Yeah, very well, thank you. We're also joined by our guest today, Anzeena Chowdhury. It's really great to have you here. You've recently joined us, and she's also a non-independent prescriber and a newly qualified pharmacist. Welcome to the podcast, Anzeena.
Hi, thank you for having me. It's been an honour to be here.
Oh, it's great to have you here. Thank you. So today we've got a really interesting topic. We're going to be discussing what you can and can't do as a non-independent prescriber. So before we get into that, it might be helpful for our listeners, Anzeena, if you can tell us a little bit more about yourself and your role, really.
Okay, so I work from Manchester. I'm currently working remotely for one of the PCNs in the North Central region. And it's been 8 weeks since I've transitioned over to primary care. So I'm still fairly new as a pharmacist. I'm now approaching my 3rd year post-registration. My background is community, where I've worked as a locum pharmacist, and I was also given the opportunity to manage a pharmacy as well. And now I've transitioned over to primary care.
Lovely. Could you also tell us a little bit about your journey transitioning into primary care? How that journey has gone for you?
So the main reason why I wanted to become a pharmacist is because I like to teach people and support them. In pharmacy, I'm able to educate patients about the conditions and counsel them on the medication. In the community, I didn't really get to do that as much as I thought I could. There was always demands to check prescriptions, and when it came to counselling a patient in the consultation room, I was always conscious of the time and how long it would take. So fast forward to last September, I enrolled onto the clinical pharmacy diploma with the University of Manchester. And my academic advisor said that I don't have to wait until I finish the course. I can start applying for clinical pharmacist jobs. So initially I was looking at NHS 111 advisor roles, but there wasn't any nearby in my region. And at the time I was looking for remote work. So I applied everywhere on Indeed, but they always wanted someone who's got 1 year's experience and knows the system already. And then I saw an advert from Clinical Pharmacist Solutions, and it said experience is advantageous. So I sent my CV, and then I researched about CPS, and I stumbled across the academy. And I remember it was Black Friday, so I bought the course for half price. And I spent the weekend learning the basics about the systems and the roles. And there was also some interview tips on the website, which I used to prepare the next stages. And that's when I realised that anyone can actually transition to general practice. You don't need a clinical diploma. The accelerator program actually gave me the foundation that I needed to learn more about the systems and how to actually basically start off doing the tasks. So yeah, I assumed that you needed a hospital background, and I'd never go near the jobs that said clinical. But I'd always admired the pharmacists that had these roles, because I thought they were very clever and you'd need more experience. So I think confidence definitely plays a big part in this as well. Now 8 weeks in, I feel more confident in this role, and I'm definitely coming more out of my comfort zone quite a lot, with different tasks and queries that come my way. We don't know what the patient's going to ask us, but I've been trained, and I know where to look for the answers in terms of like going to the guidance and the guidelines.
But that's really interesting. If I can just jump in as well. So I'd like to thank you for highlighting the fact that, as you said, you don't necessarily have to have an IP qualification or, a clinical background per se, as you said, for example, a hospital background to be able to make the transition into primary care. So I think that's a common misconception that many pharmacists have. I'm glad that, you stumbled across our training programs, and it's nice that your clinical supervisor gave you the advice to go ahead and start applying for jobs, because I think a lot of pharmacists, they do hold back thinking I don't have a prescribing qualification, or I don't have a clinical background or a clinical diploma, or I've never worked in a clinical setting like hospital, but you can indeed go ahead and apply.
So that's more about my journey and how I've actually come into primary care. Obviously, there's still a lot to learn, and I'm looking forward to continually training with the academy. There's lots of courses that are available as well. At the moment, I'm looking at the different medication reviews, so that's something that I look forward to doing in the future.
That all sounds really good. It's great to hear as well that you've grown in confidence within the role. I think that's really important. Do you think as well that you could tell us a little bit more about what you've learned so far in terms of what you can and can't do within your role?
Yeah, so I've actually made myself an acronym. It's called Clinical Pharm, and it's basically summarizes what you cannot do and what you can do as a non-independent prescriber. So if we start with the first 5 letters, so C, obviously cannot, and then you've got letters, initiate, new diagnosis, and issue. So going back to the letters, when we are given a letter, we're instructed to add a medication onto the repeat template. But what we have to do is be careful as to who's instructing us to add it onto the medication list. So if it's a consultant, then I can always go back and say as instructed by the consultant, or as directed by the letter dated such and such a date. But there was one query from a counsellor, and she suggested that we give the patient melatonin. And obviously, because the counsellor didn't have a prescribing qualification, that letter request was sent to us. So in that situation, I wouldn't be able to add it onto the repeat template. I would have then forwarded it on to the GP to have a consultation with the patient. I think I actually told the patient to book an appointment with the GP. So that's when it comes to letters, you need to be careful with what you can and can't do in there. So the next letter, I, initiate new treatment in suspected or unconfirmed diagnoses. So obviously the doctors, they need to go through lots of investigations before they can confirm a diagnosis. So we shouldn't initiate a treatment before the diagnosis is in place. Even something as simple as hypertension, I saw yesterday that looking at the notes, it was still high blood pressure. They didn't officially diagnose it as hypertension until they've actually gone through all of the different checks that they need to do. So that's definitely something that I need to do, and not to newly diagnose a patient as well. So that goes on to the next letter, N. And then I for issue, not to issue a request for an acute medication that's never been prescribed before. That's definitely some of the things that we shouldn't do as a clinical pharmacist. But one thing that I've realised in this role is that there's more things that I actually can do than can't. So there's sometimes things that I think, okay, I can't do this. This is something that the GP needs to do. But then when I go back to query it with my colleagues, they actually say, yes, you can actually go ahead and do that. For example, a letter might tell me to prescribe a low dose vitamin D, but using my clinical knowledge, my background as a pharmacist, I am actually allowed to prescribe cholecalciferol 800 units, for example, 1 a day. So that's just an example. Sometimes the letters can be vague, or just add a calcium channel blocker, but using my degree and my clinical knowledge, I would then be able to implement it and add it onto the repeat template using my clinical judgment. Is there anything else that you wanted to add to that, Runa?
Yeah, I think you've made some fantastic points, and it is great that you've created a little acronym, Clinical Pharm. Hopefully, we can share that with the audience that's listening. And I just wanted to add one more point with regards to, the example that you said that you came across yesterday. As you said, a patient wasn't actually officially diagnosed with hypertension. but the doctor had just written, perhaps the patient was suffering from high blood pressure. So if it's just written like that, that can be, just be a symptom in that moment in time. Not everyone who walks into the surgery and, if we record that their blood pressure is high at that moment in time, we cannot diagnose them with hypertension. So I think it's important that you've highlighted that, and rightly so, as you said, as a non-prescriber, there are some things that you cannot do, and all those examples that you went through were very helpful. So just to highlight the few key points that you mentioned was, as a non-prescriber, you need to make sure that you're not actually taking the responsibility to diagnose and treat a new condition. As you said, the wording on a letter from secondary care or any other clinic letter is very important. If they're just making a suggestion and that suggestion is not actually coming from a prescriber themselves, then you need to make sure you don't take that responsibility as well. You need to make sure that you don't take that responsibility on as a non-prescriber. So yeah, wording is very important. And then the other thing that you mentioned was to issue a request for an acute medication that's never been prescribed before, because then you're basically relying on either the patient's self-diagnosis or and essentially what that means is, if you go ahead and issue that, you are taking the patient's word for it, and you're even taking responsibility for diagnosing and treating that condition. So yeah, all very good points. And as you said, there's actually more that you can do as a non-prescriber. I think sometimes some pharmacists who are especially new to the role, if they're a non-prescriber, they might think that there's very little that they can do. But as you've rightly mentioned, you've probably discovered that there is more that you can do than you can't. So I'd love to hear, some of the things that you've been able to do in your role.
So going to the remaining of the acronym, so you've got CAN, action, letters, process, hypertension, alternatives. I'll go through each letter individually. So what can I do? So going on to A for action, I can action cough alert, but I'll be honest, that's something that I need to work on myself, but I know that's something that I can do. And I can also add and assign read codes. So when you receive a letter, there's always like diagnoses, and it's always important, especially if it's a past diagnosis, it's always important to check whether that diagnosis has already been added, because sometimes it does get missed off. So just making sure that these read codes are added onto the system. So L for letters, it's basically we process the letters. Sometimes we have what's known as shared care. So if it's, for example, something like Parkinson's disease or maybe epilepsy that would require hospital monitoring or a consultant, then we call that shared care, where they would go and do the monitoring. They would monitor the patients, do the blood tests, but they would also feedback to the GP surgeries and let them know what the medication the patient's on, and for us to continue prescribing that in the community. So we always receive letters, and we might receive updates from A&E or discharge letters, and that's when we need to do what we call the medicines reconciliation to see what medication's been stopped, what medication's been added, and also contacting the patients and making sure that they're aware of these changes as well. So we'll be processing clinical letters, discharge summaries. H for hypertension. So as a clinical pharmacist, we can, even though we can't initiate a drug, we can up titrate and down titrate medications. So I put hypertension, but also there's pain medications, antidepressants. We would have that consultation with the patient and see, for example, with a medication, antidepressant, to determine whether a patient's stable or not, we would do what's called a depression medication review, and we'd find out whether the mood's stable, whether they're eating and sleeping well, whether they've got any side effects, are they compliant with the medication. But the main thing that we'd find out also is whether they've got any thoughts of suicide and self-harm, whether they've got a support network at home, and also to safety net yourself that if they do have those thoughts, then to call NHS 111 or let the surgery know right away. And that's how, from having this conversation, we'll be able to see, are they currently stable on that dose? Do they wish to come off, or do they wish to be up titrated? And there's a policy in place, but you can also refer back to the NICE guideline, and they will obviously advise us on how to titrate. Similarly, today I just had a patient wants to come off duloxetine, and they want to know whether they can just come off it straight away. So I referred back to the NICE guidance, and you would titrate them off over the next 2 weeks, so you'd halve the dose each time. In terms of the hypertension, we've got a policy in place in the practice. If they come to like you're mentioning, Runa, if they come to the practice with high blood pressure, then they would be given a blood pressure machine to take home, and they'll take blood pressure readings for the next 7 days, morning and evening, and then they send it to the meds management team. We'd then calculate the average, and then according to the policy, if it's above the threshold for the age of 80, and for home blood pressure readings, if it's above 135, then that would indicate that they have hypertension. So we would up titrate them onto the next step. We can now diagnose them as hypertension because of the policy in place. But if they're under the age of 40, then I would refer them to the GP to book an appointment. So that's just, you have to look at the practice policy as well, to make sure that that's okay. So because I've got that go ahead, I am now okay to diagnose the patient with hypertension after those steps have been taken.
Yeah, and if I can just jump in quickly, Anzeena. So it's clear that you are quite competent in these clinical areas, and you seem to have a very clear guideline of the framework that you are able to work within. You've had the go-ahead from the GPs at the practice. You've obviously read up on the NICE guidelines with regards to these clinical areas that you mentioned, for example, hypertension and depression being the two that you mentioned. I think it's important to highlight that although you are not a prescriber, if you are competent in a clinical area such as hypertension or depression, if you are aware of, the management plans, the differential diagnosis for that particular condition, the treatment plans, the red flags, and you are clear with, when to refer, when you feel like a patient or a case may be a little bit more complex than the usual ones, that when to pass those back to a prescriber, for example, then you certainly can up or down titrate. And I think it's a good idea, particularly if you are a non-prescriber who is working in primary care. It's a good idea to read up on the more common clinical areas that you see on a day-to-day practice. So hypertension and depression are very good areas to start with, just because it fortunately it is very common in primary care. So if you're able to not only review those patients, but also up or down titrate, the management plan for those patients within the framework that you've been given, you can provide so much value to the practice team and be a key member. So I think, pharmacists, although you may not be a prescriber yet, don't shy away from getting involved in reviewing some of these chronic conditions. If you are competent within that area and you've been given the go-ahead by the GPs at the practice or anyone else who's supervising you in your work, then it's a great and great thing to do, and it's very rewarding as well. Back over to you, Anzeena, with your acronym.
So A for alternatives. So we can give alternatives. If a medication's out of stock, we can switch the formulations. If the diagnosis is confirmed, then according to that diagnosis, we can then go back to the NICE guidance and see if there's any alternatives that we can give altogether. So initially I thought I was giving them a new medication, I was initiating something new, but actually it's because there's already a diagnosis in place, I can go ahead and do that. So at the moment, for example, Eutogestrone, I don't know if the pronunciation is correct, but that's currently out of stock, and what we would give as an alternative is Provera. But again, just because that's the alternative, it doesn't mean the dose is the same for all. So again, go back to the guidelines, make sure that the dose is fine. So is it a cyclical dose or is it a continuous dose? Is it Provera 5 milligrams or 10 milligrams? So always go back to the guidelines and just make sure that it's a direct alternative, if you like.
Yeah, absolutely. I think, as you mentioned, so you definitely have to take into consideration, all those prescribing aspects. So all those prescribing considerations, make sure that it has the similar sort of side effect profile. Are there any new cautions or contraindications that you need to consider? And is there any new counseling points that the patients need to be made aware of? So yeah, absolutely.
So going to the last two letters of the acronym, remove. So we can remove medications from the repeat template. So when I'm doing a medication review, or if I'm just authorizing medications, I would just make sure that if there's anything that's out of sync, then it might be that they'd need another acute prescription to be able to tally up to the rest of the medications, if you like, to synchronize it all as one. An example today, a patient's on indapamide and paroxetine. So he has to keep ordering it twice a month, and he wanted them to be synchronized. So gave him a call, and it turns out that he has more of the paroxetine, so he could wait for another week until he can order it with indapamide. So just first of all, having that conversation with the patient, making sure that they do need the extra tablets, or how can you safely go about synchronizing them. Also, when I say remove off the repeats, if they've not requested something for more than a year, then you can stop the medication and put at the pharmacist's request, and then just maybe put last issued 2020, for example, so that there's a reason in place as to why you've stopped the medication. So just on that note, any action that you do, just make sure that you've got a backup, you've got a reason why you've done it. When I add something new onto the repeat template, you have an administration note. So I'll put in there as per endocrinology letter and put the date, so that when someone's doing an audit as to how this medication started or why this medication was stopped, you've got something in there for them to kind of go off.
Absolutely, yeah. I think that's a very good point that you've highlighted, Anzeena. Documentation is so important. As you say, we need that audit trail, so that you've displayed your clinical decision making. If it was to come into question for whatever reason, and of course, it helps between passing over the information to the next clinician who's opening the patient record. So you're all on the same page, and everyone has the correct information that they need to be able to make appropriate clinical judgment and continue treating that patient.
Definitely. And that goes on to the last bit, which is my favorite. I love doing medication reviews. So that's basically the last letter of the acronym, what we can do. Because I'm in my second year, so I missed the MURs in the community, so I never actually got to do them because it expired by the time I became a pharmacist. I'm glad that I got to use the opportunity to do medication reviews. Now, you've got two types of medication reviews. You've got note-based medication reviews, where you just look at the patient's records and see whether the blood tests are on time. Are there any dose changes from recent letters? Are there any interactions with the medication? And then reauthorize it that way. But the main thing you can do is, with the medication reviews, is contact the patient and have that conversation with them, see how they're getting on with the medication. I just thought it'd be important to note that you can do note-based, because at the moment in the practice, we've just the medicines management team just started when I went to that surgery, so there's quite a big backlog of medication reviews that needs to be done alongside the medication requests as well. So you can do note-based reviews if it's safe to do so. But when it comes to things like antidepressants, you need to make sure that you do that mood review, make sure that you've covered the red flags. Are they having any thoughts of suicide or self-harm? So again, in that area, use your clinical judgment. Can this be a note-based review, or do I need to speak to the patient to see how they're getting on with the medication as well?
Yeah, no, that's very all very good points, Anzeena. Thank you. And just to add to that, with regards to note-based medication reviews, so these are what you might call a level 1 medication review. So an example that I can think of what comes to mind is perhaps someone who's just on, 25 micrograms of levothyroxine, for example, and that might be the only thing that they're on, and you know that they're ordering it regularly, and all you need to do is check that their monitoring is up to date, is a TSH with a normal range within the last 12 months. And that's probably, maybe a good example of someone that might be suitable for a note-based review if you're, as you said, the surgery is really running behind, and save those patient-facing consultations or those telephone consults for those patients who, as you said, might be on medication like antidepressants, or some of the more complex patients cases where, a conversation is definitely needed. So yeah, thank you so much, Anzeena, for taking us through all of those. You've given us a very detailed breakdown on what you can and can't do as a non-independent prescriber in primary care. Just a couple of things that come to mind actually that you perhaps may not have touched upon that I can think of right now, is requesting blood tests and other necessary monitoring. So as a pharmacist, whether you're a prescriber or not, this is something that you can absolutely do. And we know that it's one of the key things, or one of the key parts of our role as a clinical pharmacist in primary care is checking the monitoring of certain drugs and medical conditions and requesting those blood tests, any other necessary monitoring such as ECG if someone's on amiodarone, for example, blood pressure, pulse checks. Another one that I can think of is perhaps making referrals to specialists or secondary care, and this would be for in areas that you are competent in. So if you are confident that a particular patient needs to be seen by a specialist or needs to be referred to secondary care, then you can go ahead and make that referral. And I think just to wrap up as well is if you're unable to deal with a particular task, and you may not be sure whether, as a clinical pharmacist, should you be expected to carry out this particular task or not, you can always ask your colleagues. So what you don't want to do is pass back something to reception or the GP saying that I'm unable to do it, when in fact it's something that you, as a pharmacist, you should be able to do. So for example, if someone says, can you provide an alternative eye drop, for example, and you pass that back to them, it's not going to look very well on you, if that's something that's normally expected from a pharmacist, even though you may not be a prescriber. So I think it's always a good idea to just check with your colleagues, is this something that I'm supposed to be doing? And if it does turn out to be something that is above your competency level, you can do whatever you can in terms of information gathering, taking some information from resources, for example, so that when you do pass it back to the GP or whoever it may be, you're demonstrating that you have used some of your clinical expertise, and it will make the job for the GP a little bit easier because you've provided them with that information. So you might say, I'm unable to do this for XY reason. This is what the guidelines state, and you can even make a recommendation, and then the GP can make the final decision. So I think they would appreciate that, and it goes a long way. So yeah, I think that's pretty much everything that I can think of right now. What we actually have as part of CPS is we've created a guidance document which clarifies all the points and all the different tasks that a non-prescriber can and cannot do in primary care. And I'd love to incorporate your acronym. I know you said you want to tidy it up a little bit, but I'd love to incorporate your acronym, Anzeena, into this guidance document. And what we'll do is we'll release that as a free resource on our Academy platform. So please go on and check out clinicalpharmacistacademy.org to get your hands on that. So I think that's all from me. Becky, have you got any other questions for Anzeena?
Yeah, well, I think, they're all really interesting points. I think just before we finish, Anzeena, a question for me is just, is there any advice that you'd want to give to those that are listening that are wanting to transition into primary care?
When I initially started, there was this, it's a self-assessment document that you can find on the academy. So I did that before I started the accelerator program. And then as soon as I did the accelerator program and did it again, I found that I actually was ticking most of the boxes for level 1 and 2. Is it called the self-assessment, Runa?
Yes, I believe so. It's the clinical pharmacist self-assessment, I believe.
Definitely do the accelerator program. Even if you don't intend to work for Clinical Pharmacist Solutions, it definitely looks good on your CV. It's a 10-hour CPD and it's well recognised amongst the GP surgeries as well. Second of all, have confidence in yourself. Don't underestimate your role as a pharmacist and your qualification. Also, keep applying on Indeed or wherever you can, and expect lots of rejections before you find the right job that comes to you. I think I probably applied to so many roles, but don't let the rejection dishearten you. I'm sure that if I was to apply again, not that I will stay with Clinical Pharmacist Solutions, but I'm sure I'll be in a better position now. And also be up to date with your clinical knowledge. Go back to the NICE guidelines, read the BNF. But to be honest, when I did the accelerator program before I actually started the course, if I was to do the accelerator program now, I'll probably understand it a lot more as well, because a lot of it is actually in practice as well. Putting your knowledge into practice, you'll remember it more. And also have a CPD portfolio. The employers like to see that as well. And have like a 5-year plan in place, what you have planned in the long term. Again, there's interview tips on the CPA website that gives you that guidance as well. And last of all, make sure you have a support network. If I didn't have the academy behind me, then I would have felt isolated in where I'm working. Currently, we have a Telegram group, so any questions that I have, I'm always asking them to make sure that it's the right action to take, whether it's relevant to forward to the GP, etc. So there's also, I think there's a clinical pharmacist network group outside CPS that you can also join. So there's loads of Telegram groups out there. Just make sure that you're with other pharmacists. Being in the company of other pharmacists, you'll start to appreciate your role, and you'll have that confidence as well.
Thank you. I think that's been a really useful few pieces of advice there, and it's definitely been a useful discussion. So hopefully our listeners found it interesting. Thank you, Anzeena, for joining us. It's been really great to hear your insights and to hear about how your journey's gone. And thank you as well, Runa, for joining us.
It's my pleasure. Thank you, Becky.
I think that's all we have time for today, but if anyone does have any further questions, any of our listeners, please do get in touch. You can contact us via our website at Clinical Pharmacist Solutions or via any of our social media platforms. So that's LinkedIn or Instagram or Facebook. And it'd be really great just to hear your thoughts. Thanks, everyone, and thanks for tuning in.